Today we are going to discuss squamous odontogenic tumor. It is an odontogenic tumor which is derived from epithelium. It is very rare tumor and mostly found between roots of teeth. It is largely asymptomatic and radiographically presents as radiolucency. Now, what are the main concepts behind naming this tumor as squamous odontogenic tumor? As we all know, the tumor has some certain clinical and microscopic features, so it is not considered as carcinoma based on clinical and microscopic features. As I have already told you, it is an odontogenic tumor because it is derived from tissues forming odontogenic apparatus. Here in this case, rests of molasses or dental lamina. So, it is an odontogenic tumor which is composed of islands of cells which are exclusively squamous cells. Here in this case, the mitotic figures and pleomorphism of cells is very rare. Because we have to know that islands of cells are also seen in ameloblastoma. So we have to differentiate these islands of cells from those islands seen in ameloblastoma. So what are the similarities of squamous odontogenic tumor with ameloblastoma? Number one, the islands are present in both tumors. These islands are composed of epithelial cells, and surrounding these islands is fibrous stroma. What are the differences histopathologically from ameloblastoma? In case of squamous odontogenic tumor, the cells in periphery of islands are not columnar. They don't undergo reverse polarization of nuclei, and there is no stellate reticulum layer. Again, the number of islands are more in squamous odontogenic tumor than ameloblastoma, and these tumors are also smaller in size. In 1975, Poulon et al. Described an entity named as squamous odontogenic tumor. It is known to occur in wide age range from first decade to eighth decade of life, but it is mostly seen in fourth and fifth decade of life. The mean age of occurrence is 38.2 years. It is more in males than females in the ratio of 2:1. It is slow growing tumor, asymptomatic, but it can cause mobility or displacement of teeth. These are intrabony, but some peripheral cases are seen. It is seen usually in anterior maxilla or posterior mandible, and around 1/4 of these are multiple lesions. The etiopathogenesis is that it arises from rests of molasses in periodontal ligament. The prognosis of this tumor is good. There are low chances of recurrence and no malignant transformation is seen. Peripheral squamous odontogenic tumors, they are very rare tumors, occur in soft tissues, and radiographically they may cause some saucerization of underlying bone, which is considered mostly as a pressure phenomena rather than result of true tumor infiltration. What are the radiographic features of squamous odontogenic tumor? There is well-defined unilocular triangular radiolucency seen between roots of teeth. Again, the root resorption or radiopacities seen in other odontogenic neoplasms like adenomatoid odontogenic tumor or calcifying epithelial odontogenic tumor are not seen in squamous odontogenic tumor. So, this radiolucency is well circumscribed, it is semicircular, it has got sclerotic borders, and if squamous odontogenic tumors are large and extensive, they may show multilocular pattern. Histopathologically, anastomosing islands of benign stratified squamous epithelium within fibrous stroma are seen. They may contain keratin or psammoma bodies, which is very rare. They may show epithelial vacuolization and microcysts, which is again very rare. And important feature is that there is no atypia, no mitotic figures, no peripheral palisading, or there are very less inflammatory cells. These are feature of ameloblastoma. In this picture, we are seeing a large number of islands of cells. These islands are composed of squamous epithelial cells. These are of different shapes and sizes, but when compared to ameloblastoma, these islands are comparatively smaller in size, and the surrounding tissue is stroma, which is made of connective tissue and is composed of collagen bundles and fibroblasts. So these islands are la these islands are composed of squamous cells. There are no columnar cells. There is no peripheral palisading of cells. There is no reverse polarization of cells, and there is no atypia, and there are no mitotic figures in each of these epithelial islands. They can be of various shapes. Keratin pearls, microcysts, and intraepithelial calcification is very rare. Then circular areas of fibroblasts and fibrous condensation or hyalinization is seen around these epithelial islands. It is considered to be connective tissue reaction to epithelial proliferation. What is the differential diagnosis? Histopathologically, they resemble ameloblastomas, but we can differentiate these because in ameloblastomas there are tall columnar cells bordering the island, and these have got reversely polarized nuclei. But here the island is exclusively made of squamous cells. The lack of peripheral columnar cells and palisading nuclei establishes the differential diagnosis between two tumors. Second important differential diagnosis is squamous cell carcinoma. Squamous cell carcinoma has again epithelial islands, but these epithelial islands have got nuclear atypia. There are a lot of mitotic figures seen. There are keratin pearls here. And they are infiltrative. So, histopathologically, we can distinguish these tumors. The treatment of squamous odontogenic tumors involves conservative local excision, curettage, enucleation, and scaling of adjacent teeth. The recurrences are very rare and prognosis is good. Now, to conclude, some multiple choice questions. Question number 1. True about squamous odontogenic tumor. Option number E is correct because it is considered as epithelial odontogenic tumor. It is asymptomatic. It is found between the roots of teeth, and correct option is all of the above. The differential diagnosis of squamous odontogenic tumor is not, it is ameloblastoma, correct. It is squamous cell carcinoma, it is lateral periodontal cyst. Here the correct option is dentigerous cyst. Mostly occurs in a posterior region. The radiolucency is large, and we can distinguish histopathologically again, and based on size here can differentiate squamous odontogenic tumor from dentigerous cyst. Among all these options, the best option is dentigerous cyst. Histopathological features of squamous odontogenic tumor includes islands of squamous cells. There is no peripheral palisading of cells, and there is absence of stellate reticulum cells. So all of the above is the correct option. Which of the following about origin of squamous odontogenic tumor is true? See here, the best option is option number A. It arises from resticomalysis. It doesn't arise from dental papilla because it is not an ectomesenchymal tumor. It is not non-odontogenic tumor, and it doesn't arise from osteoblasts like any bony tumor. So this is all about squamous odontogenic tumors. Many thanks.